Hi everyone, Sarah here from Migraine Foundation, Aotearoa, New Zealand. We hosted this webinar on Thursday the 30th of October 2025 in what was a really informative hour with neurologist Dr Rosamund Hill. We've had some fantastic feedback after the event for those who attended. We'd love to continue running more webinars and events like these so you can continue to learn as much as you can about migraine. Please consider becoming a Migraine Foundation regular donor. It's only through donations we can continue to support you and advocate on your behalf. We're the only migraine charity in New Zealand, and with no government funding and a challenging charity funding environment, it's only through the financial support from you that we can continue. Thank you.
All right. Okay, I think everyone, 7 o'clock, I think we're all ready to go. Does someone want to give me a thumbs up in the chat or put something in the chat box to make sure that everyone can hear myself and Ros?
I haven't said anything, so there you go.
I'll say something. Okay, fantastic. Thank you. Thank you. Okay. So yeah, thank you to everyone for joining us for tonight's webinar. I'm Sarah Cahill. I'm one of the co-founders of Migraine Foundation Aotearoa, New Zealand. Our charity has been operating for just over 3.5 years. Our key objectives are to connect and support people living with migraine, increase awareness of migraine disease and advocate for positive change, create and disseminate robust information about migraine, support New Zealand-focused research on migraine and collaborate with researchers in planning, recruiting and dissemination of findings, and build a sustainable, trusted and respected national migraine organisation. So I'm joined tonight by Dr Rosamund Hill. Ros is an Auckland neurologist and one of only a few migraine and headache specialists in New Zealand. Ros works in private practice, in public practice at Auckland City Hospital, and concussion clinic, and is an independent concussion expert for New Zealand Rugby. Ros is also a member of our clinical advisory group. So welcome, Ros, and thank you for being with us here tonight. So the format for tonight is just a question and answer session. So everyone who registered had the opportunity to submit a question, and we've received a lot of really great questions. I'll try to get through as many as I can tonight. Apologies in advance if I don't get to your question. We've had over 90 people register to attend, although thankfully not 90 questions. We've got the chat function is available, and I'll try and monitor that as well and see if we can get some, if we've got time, we'll get through those questions, or if there's anything that you need, would like Ros to clarify as she's talking. Someone said that they can't hear anything. I've just seen that on the chat. Can everyone else hear us? Could someone give me a thumbs up if they can hear us? It might just be that one person. Yep, okay. So it looks like, yeah, everyone can hear us. We'll also be recording this webinar, and which we'll post on our website and also on YouTube. Okay, fantastic. Yes, looks like people can hear us. Okay, so Ros, so to kick things off, we've had a couple of questions about chronic migraine and medication overuse. What does a treatment plan look like for people who have rebound migraines, need to reduce triptans but still function? This person says, currently I take sumatriptan 5 times a week, which I know is over the recommended amount. Without this, I cannot work or function. And would a neurologist have to manage a treatment plan, or can a GP?
Okay, very good question. Obviously, the fact that you're needing to take triptans 5 days a week means you're getting a lot of migraine, so average sort of 20 days a month. And that would mean you really do need to be on preventive treatment. So I'm assuming you've also been prescribed some preventive treatment. But basically what needs to happen is for you to have a better preventive option so that you don't need as much sumatriptan. In the short term, it's very difficult to just say take less sumatriptan because, as you say, you can't otherwise function. So you kind of need a better preventive plan that allows you to withdraw your sumatriptan. Now, you can cold turkey the sumatriptan and just stop taking it, but that'll generally give you a really bad headache for sort of 4 days to a week. You're likely to be in bed, and sometimes we admit patients to hospital to do exactly that. So it's not for most people a very reasonable option. So the more practical option is to introduce some kind of preventive treatment that works better than what you're currently doing, that allows you to either introduce the preventive drug for a few weeks, get it up to a reasonable dose, and then stop your sumatriptan, or just slowly reduce from 5 days a week to 4 days a week if they gradually improving with the preventive treatment. And obviously there are a selection of preventive treatments, both funded and unfunded, and you're likely to need a combination of them, not just one drug, if you've got that amount of migraine. But certainly 5 days a week of triptans is not a position that's tenable on a long-term basis, because you'll end up being 6 days and then 7 days, very likely. So you most definitely need a better plan. One would hope the GP could do it in conjunction with you, particularly if you've read about the different preventive drugs, which there's good information on the Migraine Foundation website. So you might go to your GP and say, look, I haven't tried this preventive drug. I've heard good things about it. Could I try this? So you could help your GP and do it together. If it's quite challenging and you've failed a lot of preventive drugs, you very likely will need a neurologist to help with it.
Okay. And these, I guess it would depend on individuals if they've tried medications. Like, are there ones that you would recommend to try if they've never tried a preventive, or is that very patient centric? You would have to, like, there's no.
No, there's some that are, there are some that are sort of more mainstream and some that are further down the list. But yes, you're right. It does depend on the individual, their other health conditions, and the side effects of the different preventive drugs. So some people will say, well, actually I quite like that side effect, I don't sleep very well, so some amitriptyline, which is a bit sedating, might help me sleep. Or somebody else whose blood pressure is a bit high might say, well, actually one of the blood pressure drugs would be good. I tend, as a general rule, to look at starting with one of the blood pressure drugs. I often use propranolol or candesartan, and we use a lot of amitriptyline and nortriptyline in New Zealand because they've been around a long time. We know everything they do. They're generally sort of predictable and fairly safe. They're not always effective and they're not always tolerated, but we tend often to start with those because they're not going to cause any major trouble. Topamax and Epilim are problematic for women of childbearing potential because you can't get pregnant with those. So they're a little trickier. Not to say you can't use them, but you have to be basically on some form of contraception and also be aware that should you fall pregnant, you just immediately stop them. So,
So it is that trying to find that preventive medication, because ideally shouldn't be using triptans that much. So it's trying to find that trial and error of what preventives work. Thank you. Also on chronic migraine, someone has asked, what would be your top lifestyle advice or tip for living with chronic migraine?
That's a tricky question early in the evening. I guess of all the sort of lifestyle things, and the lifestyle things include diet and exercise and sleep and stress management and hormonal management. I think it's really important to identify whether hormones are a significant trigger or not, because if they are, then some hormonal management is well worth looking at, because sometimes it's like you're more going to the source of the trigger by removing the hormonal fluctuations or by reducing the amount of estrogen or whatever. So I think in terms of, not that that's kind of really a lifestyle factor, but I think that's an important factor. After that, I think sleep and mood would be the two big ones that I think are really important. I think, and they often travel together. I think if your sleep is not good, then that makes a big difference to a lot of things. So I think sleep is very important, and then mood. So things like exercise are important, but they kind of fit in again with the sleep and mood. So it is hard to pull out, you know, one or two that are more important. But if I had to say, I'd probably say sleep and mood is kind of stress, basically. I mean, I think we all know stress is a very big one for triggering migraine. So stress, mood, I put together, and then sleep, I think are very more than food, let me say.
Yeah, we've got a couple of questions about food coming up, which is so quite a specific question. I seem to have developed an allergic reaction after taking rizatriptan. It's like terrible hay fever. Have you had others experience this? And she's given a bit of context, and she's a 54-year-old woman. Is that something that you've come across with rizatriptan?
No, not commonly. There are a lot of triptan effects, and sometimes people don't realize that what they're experiencing is a known side effect of the drug. But if this person has always tolerated it and now develops something new, I guess it's possible, but it's not a drug that's typically associated with allergic reaction very often. In that person, I probably switch to a different one, like sumatriptan from rizatriptan, because it might be the expedients, the filler in the pill, or the coating of the pill. So it might not be the drug itself, it might be something else in the rizatriptan. But the triptans themselves cause a whole lot of side effects, which I think people need to be warned about, particularly if you take it in the subcutaneous injection, because then it gets into the bloodstream very quickly and you notice them much more quickly. So often causes hot and cold sensations, tingling, tightness, often tightness in the chest, tightness in the throat, sometimes temperature dysregulation, like if you drink a cup of tea, it seems really hot when it isn't. So there are a whole lot of sensory things that occur that are all normal triptan effects. They're not side effects. So you'd want to just be sure that it wasn't a normal triptan effect, because they're quite prominent sometimes.
Yeah, it just shows that when you say they might need to try another one, we've only got sumatriptan.
Yeah,
shows
we've only got two. Yeah, we've only got two. Yeah,
exactly. Shows why we need more in New Zealand, and also other things like the GPANTs as well. So, we're working on it. So, thank you. So we had another one about medication. If a prophylactic medication, for example, candesartan, stops being effective, is it worth trying again after a break? I know we've had a few people in the support group go, look, I tried this many years ago. I've gone back to a new GP, or I've seen a new neurologist, and they want me to try this medication again. Is that worth trying?
It's actually quite common. I think over a period of time, you can feel like a drug worked well, and then over time it doesn't work so well. You put the dose up and it's a little bit better, and then you get to a point you're like, nah, and you withdraw it. But if you come back to it later, I presume one day we'll understand that there's some sort of adjustment in the system that means whatever the drug is doing, your system is now counteracting it in some way, and so the effectiveness wears off. So yes, definitely, I'll often say if it worked initially, the effect wore off, particularly if it's over like a year, so 6 months to a year, but it worked for quite a few months, then I would definitely say if you haven't been on it for a few years, well worth cycling back and using it again, and you may get again that same good response initially.
Yeah, and it's all, again, it's trial and error, isn't it, with a lot of these medications, what will work for people. We said a little bit about hormonal migraine. We've got a couple of questions about that. Someone's put, I'm on HRT patches, which I change twice a week before bed. I think I'm more likely to get migraines on the day after I change the patch. Do you think this could be true, and what could I do about it?
What that would suggest is that when the estrogen level is higher, that's triggering your migraine. So the level in your system when you first put on the new patch will be a bit higher than it is when you change the patch 3 days later. So it would suggest that when the estrogen is peaking, that's triggering a migraine. So you could try just dropping the dose slightly of the patch. Or see whether you could change it a bit more frequently using a slightly lower dose. But I'd probably just trim a bit off it. So if you were using a 75 or 100, I'd just drop the dose. You can actually just cut a little bit off the patch, make it slightly smaller, because it would suggest that the peak of the dose is a bit high, and that's triggering the migraine. It's the estrogen is a little bit high.
Okay.
So fiddle around with it and change what you do, change the dose and change how you, but it's sensible to be putting it on lastly at night, because otherwise you probably would, if you put it on the morning, it would be worse. So you're getting the highest level while you're asleep.
Yeah. Okay. That makes good sense. So, I'm wanting to change when I take Emgality, so I'm taking it in the middle of my menstrual cycle rather than just before my period starts. Is it okay to take it after 17 days as a one-off, so I can readjust when I'm taking Emgality in my cycle? I take it every 25 days at present.
Yeah, perfectly fine. Yeah, just take it one dose earlier. 17 days would be perfectly fine. Some people take 2 every month. So when they did the Emgality trials, they tried 1, which is 120 milligrams, but they also did 2. So a whole cohort of people took 2, and they did a little bit better, but not a huge amount better. So that's why they opted for 120 as the standard dose, but perfectly reasonable. Some patients will do 240 milligrams every 4 weeks. Some people will do 120 milligrams and do it a little bit more often than 4 weeks. So perfectly fine to do to bring that earlier and do it at 17 days, no problem at all.
Okay. And like, should you be doing that? Like how often should you be changing that? So say this person wants to do it 17 days once, and then maybe their periods are regular. Can you play around with Emgality that much, or is it better to stick to, the...
You could do. No, you could do if you like. Okay, I'm taking it at a certain time in my cycle rather than just taking it every 4 weeks. It would be perfectly fine if you said, okay, sometimes it's a little bit earlier, sometimes a little bit longer, because that's the way I want to do it. That's perfectly fine. The problem when you adjust things and don't keep them steady is sometimes it just makes it a little bit difficult to interpret things as to what's going on. But as long as you're keeping track of your periods and you're keeping track of when you take it, you may feel that actually that works better for you than just taking it on a 4-weekly cycle.
Okay.
It's not a problem. Yeah. People who get a good benefit from Emgality and their migraines are well settled, I'll often suggest see whether you can stretch it out a bit longer. So some people do stretch it out a bit longer. And so you could do that. And then if you find, oh, this month I've managed to get to 5 weeks, and then I started to notice an increasing frequency, but you might find on another month, you could stretch it out a bit further.
Okay.
So that's perfectly fine.
Okay. And I guess with us having to pay for it, there's also balance.
Right. Well, that's exactly. If we didn't have that issue, then I probably say, look, just stick with it every 4 weeks. But I think it's entirely reasonable, given the cost, to see can you get an acceptable level of control doing it a little bit less frequently.
Yes.
And the same with the atogepant, the Equipta. I think if it's doing a very good job, it's reasonable to try taking it every 2nd day. And I even have some patients who take it every 3rd day. So you'll know, because the migraine frequency will increase. So it's perfectly reasonable to, again, stretch it out. And it's better to stretch it out like that rather than cutting it in half. They say don't cut it, but it's not that it's a major issue doing that, but it makes more sort of sense to do it. Try it every second day rather than cut it in half and do half a day.
That's good, because I've seen that someone's put a question there about, they wanted to ask about Aquipta, if after a few months you can halve it, and so your recommendation is
recommendation is take it every second day.
Okay.
You could, there's no, you're not going to come to any harm cutting it in half, but the sort of the experts, and when Peter Goadsby was out last year, he said take it every second day rather than cutting it in half. And the reasoning for that is the other GPANT, Rimagepant, which is a very similar, that's designed to be taken every second day. So he said it's reasonable to try this one every second day as well.
Okay, thank you. We've had a question about migraine and chemo treatment. So this person's asked, do you have any advice for managing migraine while undergoing chemotherapy treatment? I guess if maybe migraines are increasing during chemo, or is there anything, do you know about people chemo migraine?
Depends on what the cancer is and what sort of chemo. So most of the experience I've had has been with women with breast cancer and migraine, and obviously that's a particular tricky situation. If you've got an estrogen sensitive breast cancer, you are going to be basically wanting no estrogen whatsoever. If you've got chemotherapy for some other cancer, then you're going to want to know, does this chemotherapy have any effect on migraine or any effect on the drugs? And typically, I wouldn't necessarily expect they would, but breast cancer is the one where it's very common that that you will need to completely suppress estrogen and usually be put into medical menopause. Now, for some women, that actually improves their migraine because you're getting rid of those hormonal fluctuations. So it does depend on whether your chemotherapy involves estrogen or not. But as a general rule, you wouldn't necessarily expect chemo to significantly disrupt your migraine. It'll just depend on the drug.
Okay. Is it okay to start if people are finding chemo is affecting migraine, making them more prevalent? You can add in other preventers if you're not on a preventive medication, just as normal, adding in drugs like that. Yeah.
Oh yeah. Obviously, if you're receiving chemotherapy, you'll be under the care of an oncologist, and so they will need to know and want to know all the drugs that you're taking for other conditions, and they'll also be interested in what are the effects that you're getting, the side effects as well as the benefits from your chemo, and they will be engaged in managing the side effects. So, but yes, typically I can't think of any particular reason why there'd be a problem with the preventive drugs. Botox is often a really good option because it's so safe and doesn't interact with anything and doesn't give you, so you don't have to deal with the side effects of your preventive medication and the side effects of your chemo. I'm particularly fond for people who've got bad migraine that's actually it's a really nice option in that situation.
Okay, thank you. I've got a couple of questions about diet. So could you explain the link between diet and migraine? What foods are proven to trigger migraine? This person asked particularly migraine with aura. I'm struggling to identify foods that are safe for me. I'd love to eat foods that are good for my gut, example, fermented foods, yogurt, but I'm worried they would cause a migraine.
Okay, so taking that in chunks, which foods are proven? None. So there is no solid evidence at all that there are any particular foods that will trigger your migraine. Having said that, there are some things that we're pretty suspicious about, and most people would agree, and the main ones are alcohol. So even if you don't have migraine, if you drink too much alcohol, you'll get a very migraine-like headache in the morning. So definitely alcohol does, but there is no evidence that any other foods reliably trigger migraine. Obviously, everybody's individual, and if you feel a certain food is a trigger, then you have to do your own little one-person trial to see. So if you're suspicious, take the food out of your diet and then put it back in your diet. And you might have to do that a few times to see whether it triggers your migraine reliably. The problem is most of us eat, lots of different foods, and so it's quite complex to identify one thing. The other thing is that previously we were suspicious and used to say, well, cheese and chocolate and, all these foods trigger migraine. What we realize now is that for quite a lot of people, in the day or two before their migraine, when there are already chemical changes started in the brain, but you may not have your aura if you get aura, and you may not have any sort of headache, but you might notice things. And so those common things can be sometimes fatigue, but some people extra energy, but also feeling like or craving certain foods. So chocolate commonly falls in that category, is people eat chocolate because they feel like eating chocolate. Then they get a migraine, then they blame the chocolate. Whether they ate the chocolate or not, they would still have got the migraine. So, and the same applies actually to things like light. So people who feel like the light is what triggers the migraine because they're exposed to some light that feels like, oh, that's too much, then get the migraine. It's more likely that you are light sensitive because the process has already started. And so therefore the light bothers you and you get the migraine. But again, like the chocolate, you are going to get it anyway. So coming back to foods themselves. So some people are sensitive to certain individual foods or groups of foods. And the only way you can really be sure about that is obviously to take those foods or groups of foods out of your diet. And you can often do that on your own by just researching foods. And the sort of groups of foods people look at are dairy, gluten, histamine, foods high in histamines, and foods high in amines. So if you want to do your own, like I want to check out because I'm suspicious about diet, then those are the things I would do. And mostly I would do, if you're really keen, 1 month, basically. Okay. So take all the most likely one is dairy. So take dairy out completely for 1 month. Then gluten, take it all out for 1 month. And if that hasn't made any difference, then put it all back in again. And then the other ones are histamines and amines. And again, you just have to research what foods are high in histamines. And there are certain foods that are high in histamines, and also food that's not fresh. The histamines go up when you leave it sitting around. So you need to either eat food within 24 hours or freeze it. But so you can research those and then go, okay, I'm going to try cutting out those groups. I say to people often when they ask me about this, I go to headache conferences. That's about the main conferences I go to internationally. Nobody ever talks about diet. There are never presentations on these are the diets. So overall, it's not considered an effective and reliable strategy to manage your migraine by trying to look at food triggers. Yeah. It generally doesn't work. Yeah. The advice about food is eat food regularly. So you're more likely to trigger migraine by not eating than by trying to figure out which food. So you want to eat a good balanced diet and eat regular meals. So fasting is more likely to trigger a migraine than eating the wrong food. Yeah. So what you want to do is eat a good regular diet. But that's not to say there couldn't be the occasional individual who has some other medical issue with their digestion or with their immune system that may mean that as part of their sensitivity to those things, they get other things and headache. That is possible, because we know headache occurs in hundreds of other conditions.
Yeah.
So it is possible, but it's certainly not standard migraine management to modify your diet in any particular way. We just encourage you to eat regular meals.
Yeah. And it's interesting when you're talking about the cheese and chocolate. There's a lot of research, I believe, coming out now. It's about the prodrome, and I know on our website we talk a lot about that prodrome stage that you've touched on. Going, yeah, people think that this cheese is triggered a migraine, but as you say, and it's been you can see those changes in the brain, can't you? With functional MRI, you can actually see those changes happening 2 days before people are aware that a migraine attack is happening. So yeah, it's food triggers can be hard if they even trigger.
Well, they can be they can involve a lot of time and energy, and if you're going through a dietitian and etc., a lot of cost, and in the end you find that that you've become quite restrictive and you haven't actually fixed the problem. So, and I never mind if people want to try, but I don't say, look, well, there's a good chance that you will fix the problem. I'll generally say my experience is that it's a lot of time and energy, and it doesn't fix the problem. And I think part of the issue is most people don't have one single trigger unless they've got very true menstrually triggered migraine. Most people, it's a whole lot of different factors that often come together that contribute to your migraine. So it's stress and poor sleep, and it's been hot and you haven't drank enough fluid, or you've had an argument. So it's like a whole lot of things, and it's a different lot of things the next time. So it's very difficult. I don't think people can commonly identify one thing or one major thing. They go, okay, I need to get to the bottom of this. If I fix this one thing, that'll fix my migraine, because it's a much more complex sort of sensitivity. Your system is more sensitive, and that's not just more sensitive to the one thing you haven't managed to identify. It's overall you've got a sensitive system, and so lots of different things can trigger the migraine.
Yeah, I mean, I'm sure I spent many years trying to identify all my triggers, and then just realized that I have a neurological condition that needs to be managed with medication and other things. But it's a long journey, and it's a journey that so many people are on, to just think, if I could just find this one thing that caused migraine, everything would be better. But unfortunately, it's not. It's not like that. There was one question about weight. Does my weight make migraine worse? So I guess just being overweight, does that contribute heavily to migraine?
The issue with weight is it increases your risk of your migraine converting from episodic to chronic. So it is a factor, but that seems to be the factor. And I don't know that we know why that is, but that seems to be, when people have done these studies looking at lots of people, etc., that came out as a risk factor for going from episodic to chronic. So yes, I guess in some ways it does mean you're more likely to have more migraine. Whether conversely, if you lost a whole lot of weight, would your migraine be better? I don't know that one could say necessarily that's the case, but yes, we do consider it is a factor in getting more migraine over time.
Okay. Yeah, I just see someone's put here, so I appreciate you validating that it's not one food or one thing. Friends and family and colleagues are forever telling me what they think will work. I think so many of us can relate to that. So we've had a couple of questions about physio and migraine. So someone has asked, how much evidence is there around efficacy of migraine-specific physiotherapy treatments?
Okay, that's a very good subject, and I'm keen to talk about that. Okay, so the thing to realize is that very commonly people get neck pain and neck stiffness with their migraine. So around somewhere between like 65 and 75% of people will get neck stiffness and pain with their migraine, and often it will come first, usually within a couple of hours of the migraine starting and during the migraine. So you can have neck pain and stiffness as part of that sort of prodrome in the day or two before. You can have it with your migraine, and you can have it in the kind of recovery phase. The issue is, does that mean there's something wrong with your neck? A lot of the time, no. But if you have neck pain at other times when you don't have migraine, then you would say maybe you've got a problem with your neck and that needs to be looked at independently. But it is very common to have neck pain and stiffness with your migraine. And we know if you look at kids, they've done studies in children, and 50% of them get neck pain and stiffness. So, and they don't have pathology in their neck the same way old people like me do, as you get wear and tear and other things. So I think that establishes quite clearly that neck pain and stiffness is a very common part of migraine. So physios, they're like, you know, there's something for them to target and work on, but it's part of the migraine. You get that. Treating it makes your neck feel more comfortable, but may make absolutely no difference. If you haven't got a neck problem, you've got a migraine problem. So it's perfectly fine to go and see the physio if you find it very helpful, but it is not something that I recommend to patients who've got neck pain and stiffness, that it's helpful to see a physio, because it's just part of the expected collection of things you experience with a migraine, and physio is not going to make a difference.
Okay.
There's another condition called cervicogenic headache. Now that's a different thing. Yeah. So now that is quite rare. It's quite uncommon. And what that means is you've got a problem with your neck that gives you headache. And it has its own clear criteria. The headache's got to come with the neck problem. You've got to have an identified problem with your neck. When you treat the neck, the headache gets better. If you have nerve blocks that fix the problem in the neck, the headache gets better. It's not just the same thing. It's actually, there is a identifiable neck pathology that gives you headache, but it's really not that common. What is common is neck pain and stiffness associated with the migraine attack. So the problem is, if it starts in your neck before you get your headache, people will often go, this must be where the problem is. I'll go to the physio. If it's here, but it's also here, people are like, I've got terrible migraine and I get neck pain and stiffness with it. And they're less likely to go to the physio and say, there's a neck problem. So it's a little bit where it starts, but that's perfectly part of the migraine process. And some people, I'll say, when it starts here and you get the neck pain, take your rizatriptan or sumatriptan. And they're like, wow, that made the neck pain go away. Well, yep, that's because it's migraine. And there is a very clear anatomical explanation as to why that happens. And I'm not going to bore you with it, but it's related to the fact that the nerves C1, 2, 3, they all they take the information from the top of your neck to the part of your brain stem and upper neck where the migraine is generated and persists. So there's a good reason why you would get neck pain in the top part of your neck. So my attitude is, if you find the physio helpful, that's absolutely fine. Do it, but don't go and do 10 sessions because the physio says this will fix your migraine, and then you find it makes no difference, because there is no expectation, regardless of what they say, that they're going to fix it. But you're most welcome to give it a try. They're not going to do any harm.
Okay. Yeah.
Somebody asked what sort of physio. Well, the headache clinic, which is around the country, I'm afraid I'm not a fan of, because one of the main reasons I'm not a fan is they charge more than other physios and they don't do anything. So the Watson technique that they do has not been established to be any better at all than any other physio technique. So what you're interested in is a physio who or might be an osteopath, who knows about necks, who's good. So you ask around and say, is anybody, I feel like my neck is always quite stiff. Even when I haven't got a migraine, I've got neck pain. So I'd like to see a physio. Perfectly reasonable. ask around. Does anybody know? Is there a local physio who's good? Perfectly reasonable. You do not need to go to somebody who does the Watson technique. Absolutely not. There are physios around who specialize in head and neck problems, and sometimes it's worth tracking down one of those, just because that's what they're a bit expert at. But so I don't have a problem with people doing it, but there's no expectation that one should do that if you've got neck pain and stiffness. Sorry, that's rather a long rant, but
no, and it sounds as though the key is working out if it's just neck pain when you have migraine.
Neck pain, lots of people get neck pain. Neck pain is very common. Migraine is very common. A lot of people are going to have two separate things. The thing is, are the two things related, or do you have neck pain and stiffness as part of your migraine, and it's not telling you there's a problem with your neck? So it's important to try and figure that out. And the main thing would be, when you don't have a headache at all, your head is crystal clear, have you got a neck problem? I'd say investigate it as a separate issue.
And we do have a article on our website about neck pain and migraine, I think, which is very similar as what you've said. Basically, if people want to read it and read what you've basically said, then there is an article on our website. So just a few questions about migraine and other health conditions. So the first question is about long COVID and migraine. Is there information or research about long COVID causing people to develop migraines, or any correlation with, they've put PEM, which I assume is post-exertional malaise? So is there with long COVID and migraine? Can you talk a little bit about that?
Yeah. COVID itself is a very headachy virus. So in the acute phase of COVID, there's often headache, and certainly there's headache with long COVID. And certainly it's perfectly feasible for people who've not had migraine in the past could get long COVID and definitely have problematic headache. And you can get that with other viruses as well, but COVID seems to be a very headachy virus. So yes, it certainly could be how it develops. If you were a person who had previously had some migraine, even one or two clear migraines, you potentially would be at greater risk of getting persistent or troublesome migraine after COVID, because that says you have a tendency to have migraine, though they've been not at a bothersome level, but it means you're at greater risk than the person who's never ever had migraine and then gets COVID. But yes, absolutely. I don't know anything specific. I don't think there's any specific evidence about the migraine that comes with long COVID, whether it's any different. I don't think there's any evidence it is. It's still just migraine.
It would still be treated the same, wouldn't it?
The same. Yeah, absolutely.
Okay. Someone has asked about migraine and mast cell activation syndrome. So they said, looking at the triggers for migraine and mast cell activation syndrome, the overlap of triggers and symptoms now makes me wonder how to treat migraine if it's actually mast cell activation. Could you talk about that a bit? Maybe explain what mast cell activation is for people who don't know. Is probably a good place to start.
Yeah, so mast cells are one of your many different types of white cells, and they're involved in allergy, basically. And in mast cell activation syndrome, basically, you have the same number of mast cells, they're just super sensitive and they get overactivated when they shouldn't, stimulated by various things. It's a immunological condition. It's not a neurological condition. There are very clear criteria on what constitutes the condition. So if you're interested, just ask ChatGPT to give you a nice little summary. There are ways to diagnose it, blood tests to measure the sort of activation of the enzymes that it activates. So it's involved in allergy, basically. And so people who've got overactive mast cells will get allergy-like symptoms. and mast cell activation syndrome can be associated with headache, but you don't get headache on its own. You have to also have other things, flushing and asthma and sensitivity, other things. So and it's not, the actual condition is not that common. So it's definitely not something that we've not recognized, but is a major contributor or causation for migraine. There could well be some people who have that, but they won't look like your average migraine person, because they'll get a whole lot of other symptoms when they get the headache. They'll get all these other things related to the sort of activation. It's treated, well, you've got to diagnose it by doing some blood tests in the middle of the actual experience of the activation to diagnose it. It's treated with low histamine diet and histamine blockers, both H1 and H2 blockers. So it's treated with cetirizine, one of the antihistamines, sometimes I think with famotidine. So it's not straightforward, but if you're really interested, you could read about it yourself. If you think that it sounds like you could do a low histamine diet for 1 month.
Okay.
And you could, if you really thought that that was you could talk to your GP and say, look, could I take an antihistamine, an H1 and an H2 blocker for a month and see whether it made a difference? They might be happy to do that.
Okay.
But it's technically quite rare. But there will be some people, in the same way you can have headache with hundreds of conditions, that is one of them that you could have it. But I don't think it's something that we commonly see or miss. But if you feel like when you read about it, that sounds just like you, then certainly follow up.
Okay. And that kind of segues nicely to, we've had a question about like multiple headache disorders. So said, how do you treat people with multiple headache disorders along with migraine? You get tension headache, silent migraine, occipital neuralgia. Do you treat them separately, or are there ways to treat them all at once? And I guess my question is, do you get people with multiple migraine diagnoses?
Most definitely.
Okay.
Firstly, yes, you do. The quick answer is yes, you do get people who have more than one type of headache. And yes, you generally treat most of them. You diagnose them individually, and then you look at the treatment that's appropriate for each one.
Okay.
Tension type headache by definition is never severe. It's only mild to moderate. So pretty much most people, almost everybody at some stage gets tension type headache. So it's a headache that's it's sort of like a tight band or pressure on the top of your head. It's a mild headache. It can be there for quite a long time, but it's never severe. I don't think most people would go to the GP about a tension type headache, and certainly wouldn't necessarily go and see a neurologist about it. But people who have migraine almost always have tension type headache as well.
Okay.
But it's tension type headache is treated the same way as migraine. So sort of the tricyclics, the drugs with a bit of muscle relaxant action and a little bit of anti-anxiety, they will often work well. But tension type headache is a bit of a non-event. It's just like that irritating, you get to the end of the day and I've had a really busy day and I haven't actually had enough to eat and drink and it's been a bit stressful, and it's like, and this, people with tension type headache often do this, and apparently 2 fingers.
Okay.
It's like, because it's partly muscle tension, because you've got quite big muscles that attach. So it's tender, so you give them a good rub, they're a bit tender. And it's said to be related to sort of high level of sort of daily niggle muscle, like stress and tension. So tension type headache is something that's very common, and we wouldn't specifically try and treat it separately. Occipital neuralgia is a whole different thing, because that's a nerve irritation giving you electric shock-like shooting pain. So there are a variety of much more uncommon conditions. So almost all headache that's bad is migraine in my book. But there are lots of other types of much less common some of them even more painful, like cluster headache type.
Mm-hmm.
So you do want to clearly diagnose what sort of headache the person has before you start treating them.
Yeah.
So headache is a kind of a broad term, and some people talk about their headaches and their migraines. What they're meaning is they're not so bad ones and they're really bad ones.
Yeah.
And that's fine, but that's not technically, you'd still want to go, when you call that a headache, are you talking about a tension type headache, or you're talking about a mild version of your migraine that if it got worse, it would be in the other category, migraine, which is often the case. Yeah.
And it sounds as though diagnosis is key to that.
Diagnosis is key, absolutely. And
Yeah.
if you think you've got some other form of headache, again, good old chat GPT, I use Grok, but the other thing you can do is look at the International Classification of Headache Disorders, which is a fantastic document online. It's easy to read, and it just shows you all the different headache types, and you can have, and the criteria for diagnosis.
Mm-hmm.
So if you're like, I don't know whether this is, this thing or that thing, then just look it up and see, actually it sounds like that. And then you might go and see your GP or the neurologist and say, look, I think I might have,
because
occipital neuralgia.
GPs can diagnose types of migraine, can't they? Because I know a lot of people struggle to see neurologists. So
oh, absolutely. So GPs should definitely be able to make a diagnosis and should get people started on appropriate treatment.
Mm-hmm.
They've got online health pathways that give them very clear guidance as to what to do. So no, the GP, most definitely, you do not need a neurologist to make the diagnosis. The GP should be more than able to do that and start the appropriate treatment. But it does help a lot if you've read about it
mm-hmm.
and have some understanding already. That's certainly good in terms of people who have a condition can often become very expert at their condition, and then the idea is you work with your GP because you may actually know more than they do once you get into the slightly challenging level of a condition, to say, actually, how about this? And that's good.
I think there's many experts and I'm sure online watching this webinar who know a lot about their condition and and can self-advocate. I mean, that's something that we've learned is, self-advocating and having the knowledge is crucial to work with your GP. A few more questions. One is about neuromodulation. So is the cephaly or the mind, which was the one that we could get here for a while in New Zealand, are they safe to use and are they effective?
Completely safe, most definitely. And effective for some people, yes. I haven't got a lot of experience with them because we haven't really had a lot of them here, but they're completely safe. And they're really great if they do work because they're not taking a tablet every day with side effects, etc. But my experience has been from the patients who have imported them. I haven't had anybody who's had spectacular results, but I'm sure there are people who found them helpful. So completely reasonable thing to try. If you've read about it and think you'd like to try it and you feel you can fund it, then absolutely, completely safe.
And safe during pregnancy, that's correct?
Yeah, absolutely. Yes.
So that's
yes,
good
definitely.
if you're pregnant and struggling. Yeah. Someone just asked here, can you repeat the place to look up the different types of headaches? That's the international.
Oh, yeah. It's called the International Classification of Headache Disorders, ICHD, International Classification of Headache Disorders, and it's version 3. I think it's even 3B. But if you just Google International Classification of Headache Disorders, occipital neuralgia or whatever, it'll come up in that part of the classification. So if you put International Headache Classification or even either any way around, it should come up. Migraine, it'll come up at the beginning where it'll go migraine without aura, migraine with aura, migraine, with brainstem aura, and it'll all be there. And then you can click and go down on further layers with more detail, but it's easy to read.
Yes, yes, yeah, I've read it. Yeah, it's probably people who have read it as well. And I see Fiona has put the link in the chat as well for people, which is really helpful. We've just got a few more minutes, so a couple more questions. There's one question about magnesium. Do you have any advice about magnesium? Is there, because there's lots of different types of magnesium that's most helpful for migraine, to help prevent migraine?
Yeah, no, it's a really good thing to try. Again, safe. The things I say about magnesium is take it for 3 or 4 months. There are different sorts of magnesium. Some of them are better, I think some are getting better. The one you don't want to take is magnesium oxide, because that's the one that you take for constipation, i.e. it causes diarrhea.
Right.
And it doesn't get absorbed, that's why it causes diarrhea.
Yeah.
So not magnesium oxide. I think the ones that are said to be better, I think, are magnesium glycinate or and magnesium threonine or something. But if you Google it, there are some that are better, but not magnesium oxide. That's the one you take for diarrhea, basically.
Okay.
And you're wanting ideally 400 milligrams of elemental magnesium. So if you, because you might buy it online or whatever, you wanted to see how much magnesium and make sure you're getting, and make, because these things are quite complicated sometimes. So you might need to Google how much actual magnesium or how much elemental magnesium am I getting? Because you don't want to be taking, a tiny dose and then say it doesn't work and you might work better. I encourage people to use Migradol because that's a New Zealand clinician's product for migraine, and it has the B2 as well as the magnesium. So that's often the easiest way to take it, and then you'll be getting the recommended amount. But you can buy the magnesium and the B2 separately, but they're fairly big doses, 400 milligrams of both a day. And then the other one is coenzyme Q10, is a antioxidant, and that's said to also be good. And you just want to buy the strongest amount. So I think 150 currently is the strongest I've seen around, but so you just want to buy the strongest coenzyme Q10 dose that there is.
And riboflavin as well. Do you recommend?
Oh, that's B2.
Oh, B2. Sorry.
That's riboflavin.
Those are the three and I think those are the three that we've got on our website as well, as if you're going to try these. And would you try, if you're not taking any supplements, would you try start all three at the same time, or try and space them out to kind of work out what's happening?
I would usually, the easiest thing is to take like the Migradol one, because that'll give you the B2 and the magnesium, or I would do the two of them on their own together for 4 months, and just see. The other one is more just generally said to be good for your health, but these things are all expensive.
They are.
So if you're going to do any, I'd do the magnesium and B2, but you could do them separately. You could just do the magnesium first, see what you think. But I think the easiest thing would be, the sort of speediest would be to do the magnesium and the B2 together for 3 to 4 months.
Yeah. And someone's asked if we put a list of these supplements in the chat. Yes, we do have a list on our website as well. If you go to the non-medication treatments on our website, you'll find a list of the supplements there as well. We've got time for one more question. I know there's been some other questions. I'm sorry that we haven't got through all of them. Someone's just asked, how can we best advocate for tests, medications which are available in New Zealand, funded or unfunded, and in particular when migraines may have a hormonal component? I guess
you're better to answer that than me.
What's that? No, I think my take on that question is like there's so many non-funded. I know when like perimenopausal or menopausal, there's lots of tests that you can read online. You get advice about so many things can be tested for. Tests, blood tests. So many non-funded blood tests, like there's the Dutch test and there's all these other tests that you can get.
Well, there are no tests I can, so I don't know anything about. No, there are no tests I can think of that someone would need to tell me what they are. But no, there's no menopause tests around menopause. are often unreliable because things go up and down and it's really tricky. But often your GP will do a test to tell you whether you're perimenopause or not. But perimenopause can go on for years.
Yes.
So and you can do tests at different times, and it's like yes, no, yes, no. So you're more going to go on what your menstrual cycle is doing, or what's happening, with your symptoms. But no, I can't think of any non-funded tests that you would do. So no, sorry, not.
And I mean, in terms of advocating for non-funded medications, I mean, hopefully everyone knows that that's what we've spent the last few years doing. It's consumed a lot of our time, and we've been successful to that the non-funded medications, the anti-CGRP medications, are sitting on Pharmac's options for investment list. They're not funded. We are still working on that, so we're still we have a lot of hope that they will get funded, and there is some progress. So yeah, we are hopeful in that time. I did see one last question that was it says, do migraine attacks lessen in frequency or intensity with men as they age? I guess there's a lot of talk about migraine getting better for some women as they age. What about for men?
For everybody overall, if you look at the incidence, it gets less and less as people get older. So for everybody, that is the natural history of migraine, is for it to get less. Unfortunately, that isn't the case. That isn't everybody's experience. So there are certainly some people it appears later in life. For women, there are some people it appears post-menopause when it's not been a bother before. But as a general rule, if you look at the data, and GPs will say often it's really unusual to have patients in their 70s with migraine. So it usually gently fizzles out, or quite quickly fizzles out post-menopause. But yes, the expectation is that it gets less, most definitely, for everybody as you get older.
Okay, so thank you. Thank you, Ros, for answering all the questions that I've fired at you over the last hour. As I say, sorry we couldn't get through all the questions that have come through, but hopefully we got through a lot of them that people have submitted. Some of the questions, I mean, have a look on our website, because I can see a few of the questions that have come through. We do have information on our website, so have a good read of that. So thank you everyone for joining us for the webinar tonight. I do hope that you all found it helpful. As I said, remember there's lots of information about many of the topics we covered tonight on our website. When you are visiting our website, I also have an ask in that you visit our donate page and consider supporting us with a one-off or regular donations, just because donations are the lifeblood of our charity. Charity funding is increasingly difficult to secure. We know that we need to keep talking about and advocating for improved migraine treatments in New Zealand, so we can all live lives impacted by migraine. So do please consider donating us and supporting us that way. So thanks again. As mentioned, this recording will be up on our website and YouTube soon, so keep an eye out for it. And thank you everyone for attending. Thank you, Ros.
No problem.
Okay. Good night.
Bye.